Okay, so this is Autism Spectrum Disorders 101. Welcome. And what I'm going to be covering today, we'll talk about the criteria for autism spectrum disorders. We'll talk about the prevalence. We'll talk about what the research is suggesting some of the risk factors are for autism spectrum disorders, signs and symptoms, and the diagnostic process, and then a little bit about treatment. Sounds like you're going to get a full primer on ABA later on, so I won't go too much into that with that. Okay, so what is autism or ASD? So you may hear me use both words for it. So it's in the neurodevelopmental disorder, developmental disability category, and it causes areas of need in two areas: social communication needs, such as looking at nonverbal communication like eye contact, pointing, use of gestures, and verbal communication skills like having conversations, forming social relationships is also lumped under that social communication umbrella. And then we also see the presence of restricted repetitive behaviors. So those can take many forms, like unusual motor movements, an insistence on sameness to the degree of affecting kind of one's ability to move through their daily schedule, and abnormal sensory reactions. So prior to 2013, we had several different autism diagnoses, such as PDD-NOS, Asperger's, and regular autism, and now they've all been lumped under this new category of autism spectrum disorders. So with the new diagnostic manual, the DSM-5, that came out in 2013, it put all these together. And the reason they did that is that when they did the research, they found that there was nothing reliably that distinguished who got diagnosed with what. It was more like a function of what clinic you went to, interestingly. So, you know, clinics kind of had a tendency to favor one over the other. So there was just a lot of confusion about that, and people were kind of using those different diagnoses incorrectly, like, you know, Asperger's is the high-functioning autism. That's not necessarily the case. So to eliminate all of that confusion, they put it under one umbrella, and they give levels of need, which I'll talk about a little bit later. But those levels of need are supposed to be fluid and reflect the individual's needs at any point in his or her life. So some people with autism need a lot of help in their daily lives, and some less. There's often nothing that to the kind of casual observer that would flag a person as having autism. So sometimes it's described as a hidden disability. So if it looks like a child has no special needs, then people might be quick to judge and say they're being willful or spoiled or so on and so forth, and when they don't really notice what's going on. So something to keep in mind as we talk about this today, you may have heard this saying, if you met one person with autism, you've met one person with autism. There's a reason it's called Autism Spectrum Disorders, because every person is truly unique. So we really have to look at the whole person and their pattern of strengths and weaknesses. Just another graphic to illustrate that concept. People can vary along many different dimensions. Some individuals are nonverbal or just learning to speak. Some have no apparent difficulties with speaking. Cognitive ability ranges, sensory needs range, social skills range, and I'll get into this a little bit more. Sometimes there's special skills, sometimes there's not. Okay, so the DSM-5, as I mentioned, our current diagnostic manual. So the new criteria, the current criteria has two domains. It has that social communication domain and restricted repetitive behavioral domain. So we need to see some illustration of each of these kind of clusters of symptoms in the social communication realm. So one is social emotional reciprocity. So it can be take the form of conversational skills. They're not sharing information that leads to bonding. Difficulties with emotions and understanding other people's feelings, not responding to social interactions. So one important thing when we're looking at autism, it's not always an absence or a presence of behavior. We have to look at quality. So somebody could be super social and want to have friends, but they're interacting and initiating interactions in a somewhat inappropriate manner, and they're not kind of understanding how their approach is affecting others. So just because they want to have friends doesn't mean they don't have autism. And any one given thing does not qualify someone as having autism. It's a pattern of symptoms. It's their developmental history. So we need to see this bigger picture. Nonverbal communication. So as I mentioned before, it can be things like abnormalities in eye contact, their body language, maybe they don't understand personal space. It can be as subtle as that. Using and understanding gestures, facial expressiveness. Sometimes we'll see kind of relatively static or limited facial expressions, or individuals won't direct them towards a person's face, because that's a form of communication. That's how we get input from our environment, and that's how we learn. So it's really important that they can do that too. So showing a range of facial expressions without using words or sounds or anything. So deficits in developing, maintaining, and understanding relationships. So as I talked about this a little bit before. So this can look like, so it's developing a relationship to a developmentally appropriate degree. So this changes over time, and so they may have, not have apparent problems when they're 3 or 4 or 5, but when relationships get more sophisticated, that can be a problem. We often look at play skills too, particularly in younger children. Are they imitating the behavior of adults? Are they pretending to cook? Are they pretending to fix something around the house, take care of a baby, or baby doll play, imaginary play? Sometimes it will seem like kids have imaginary play, but it's also important to look at, is it novel? Because sometimes kids will just act out scenes from their favorite TV show or their video, and kids without autism do that too sometimes. So again, it's no one thing diagnosis of you as having autism. So it's looking at the quality of things. And it's also understanding that what's appropriate in one setting might not be appropriate in another setting. So understanding those finer social nuances. So the second domain that we're looking at is the restricted repetitive behavior. So you need to have at least 2 illustrations of these 4 symptoms. So that can look like stereotyped or repetitive movements. So can be flapping, spinning, can be lining up toys or spending a lot of time lining them up, sorting them, moving parts of toys. And again, kids without autism do this too, but are they spending most of their time, are they setting them up and then they're playing with them in a kind of novel way, or are they spending a lot of time fixating on the parts of things? It can look like echolalia, which is repetitive speech, repeating something you heard somebody say, or an overlearned phrase, using that in kind of a scripted fashion. Insistence on sameness, inflexible adherence to routines, ritualized patterns of verbal, nonverbal behavior. It's a mouthful. So extreme distress at small changes. And you know, human beings thrive on routine. So, you know, to a certain degree, that is normal, to want a routine and to feel comfortable with a routine. But if it really throws you off, if you need things, minor things to be exactly the same, if you need a parent to say something in a certain way all the time, or it throws you off, or you have a big emotional reaction, or it's something that needs to be addressed repeatedly, that might be a problem. Difficulties with transitions, rigid thinking patterns, sometimes we call this black and white thinking. So, you know, a child might learn the rules and then they see a child apparently breaking the rules, and that can cause a lot of distress because they don't understand why the other person is breaking the rules. They don't think it's fair, or maybe that person is not getting in trouble for it, but maybe that rule doesn't apply in all situations. Highly restricted fixated interests that are abnormal in intensity and focus. So this can get tricky. Sometimes it's something unusual that you wouldn't expect, like an individual wants to memorize bus schedules or train schedules. But sometimes it can be something that is developmentally appropriate. You know, maybe they're interested in Pokemon, and a lot of kids their age are interested in Pokemon, but they spend a lot of their time watching Pokemon, learning about Pokemon, talking about Pokemon, and they can kind of shift away from that appropriately, or notice when the other person has gotten their fill of Pokemon, or connect with other people who might have varied interests. So that's where it can become a problem. And this is new in the DSM-5, although parents would always say, you know, my child has sensory issues. It was never formally a criteria for autism. And you don't have to have this. Again, you only need 2 of these, but it's been recognized in the DSM-5. So it can be things like fixating on, lights or movement, sounds. Maybe the individual, there's a fan running and they get down real close and they listen, or they put their face in and they peer at it, or they watch the blades of the ceiling fan move, or shadows, those sorts of things. It can be hyposensitivity to sensory information, so they don't register it as easily, or maybe you'll see them kind of push into things a lot because they're kind of trying to get that sensory input, and hypersensitivity too. So that can be, so they're seeking sensory information. So they're super reactive to sensory information. So that can cause problems, like, for example, if a child is in line with other children and, you know, another kid bumps into them, as happens, right? You know, they're like, he smacked me, or he kicked me, or so on and so forth. And, you know, it can look like, or they'll just haul off and smack the person, so it can look oppositional defiant, but really when you look at it at a deeper level, maybe, you know, they have some sensory issues. We want to see some evidence of symptoms before age 3, but one of the things that the DSM-5 attempted to address is that adults who were coming in and for clinical evaluations, and they didn't have anybody to report on their earlier history before they were getting excluded a lot of the times. So the absence of that doesn't mean that they don't get the diagnosis necessarily. And we have to see some impairment in different areas of functioning. So as I talked about before, we have this level system now, mild. So sometimes people would, you know, informally use this mild, moderate, severe when they're talking about autism. But now we have a severity level, and we want to look at the severity in each of those domains, so the social communication and that behavioral domain. So 1 is requiring support, 2 is requiring substantial support, and 3 is requiring very substantial support. And as I said, these levels are fluid. It's meant to reflect how is the individual interacting with their environment at any point in their life. So if they come to me at age 6, they might be level 3, but then, you know, when I test them at age 9, they might be level 2. Or, you know, they can go up, level 1 to level 2. Maybe, you know, their difficulties are more subtle. And then when they get to the teenage years, when there's more executive functioning or need for kind of independence and planning and organization, or there's dating happening, or you're thinking about career paths and things, that their needs become more significant. So a level 2 might be more appropriate. So prevalence, ASD cuts. Oh, sure.
Can we ask a question?
Yes, Abby's dead, right?
Yeah, right. What's the earliest age that these things can manifest themselves, so parents or doctors should be seeing it?
Yeah, so parents often report a concern about their child's development. They may not pinpoint or suspect autism, but something. The first kind of things that they'll come into the doctor's office with are concerns about vision or hearing, and it may not be physical vision, but maybe it's related to that eye contact. And later on, like around 6 months, motor concerns. So it's possible to diagnose 18 months or a little bit younger. Diagnoses are considered reliable at age 2. I think we're getting better and better at detecting it, and they're noticing differences earlier on. I heard of a study, I believe it was, I need to find this to get the exact information, so I may be misquoting this, but I'm pretty sure they were seeing like differences in infants' eye contact at age 6 weeks even. So they put them, how they did this, they put them in like a car seat and they had them watch this video of their mom interacting, and they looked at where their eye gaze went, and the infants that were identified as at risk for autism or later went on to develop that, spent more time looking at objects and the background, whereas the ones that didn't, weren't at risk for autism spent more time looking at their mother's face.
So when you say better at recognizing it, are you referring to the doctors that parents take their babies to? Or are you talking about the parents?
Mm-hmm.
I'm hoping you're going to say doctors, but is that true that the doctors are getting better at understanding?
I think for sure doctors. I can't say for sure parents. I feel like there's more and more information that gets out there every year. The American Academy of Pediatrics recommends that you stay vigilant and survey for symptoms at each well-care visit, and then they do screenings. Starting at 6 months, I think it's on a later slide, like checklists. It's looking at development, and if a parent brings any concerns or there are some noticeable delays, the recommendation is to refer out for further testing. But so we're getting better. I think as the research develops, we're getting a better idea of how it looks in younger children. So sometimes kids younger than 18 or 18 months is still pretty young. We might say, they're showing some concerns. So let's get them into early intervention. Let's get them to interventions that we know show promise for autism, because 0 to 2 is a prime age for brain development. And after age 2, we start to prune brain cells. So if we can capitalize on that early intervention, regardless of whether or not we call it a developmental delay or autism, then we can make more progress. So, I think everybody's coordinating better in the medical field. And a lot of times, younger kids, they'll get identified as having a developmental delay. And that could be motor, speech, social emotional skills, self-help skills, any of those, and then they get those kinds of, hopefully the right kinds of services. So as you've probably heard, the prevalence rates are going up. kind of each time they survey it. So the most recent statistics, according to the Center for Disease Control, 1 in 59 kids, it's about 4.5 more times prevalent in boys, 1 in 42 versus 1 in 189 girls. However, there's discussion that maybe we're missing some of these girls, that maybe they're presenting differently than boys, and we need to kind of be more aware of what that looks like in girls. And that's actually cuts across a lot of diagnoses like ADHD. When they first developed the criteria, it was tested, field tests were done on boys. So girls are often missed for that too, because they present in a really different way. And so some things, girls often have lower levels of the restrictive repetitive behaviors, which early on, those are the things that really flag a child. And sometimes they have a higher command of language that can make them overlooked. Any other questions so far?
Did you know, just like the medical profession, I was amazing to learn. For several years, thought if a man had a problem with a particular medical problem, would help him, would also help a woman until they found out that men and women were different.
That's true.
And what's amazing is
yes.
for me to even say that statement that men and women are different. So are they finding as they go through this that, with reason, you think they might have missed it because they're using the same kind of prejudice with regard to boys versus girls that they did in the medical profession? And they're not doing individual screening with regard to looking for these things on the basis boys and girls are different.
And again, as we do more and more research, we develop better understandings of how the ASD might present in girls. But that's a very good point, and it even goes down to how men and women metabolize medications and pharmaceutical studies. I don't know, maybe that's changing now, but a lot of times, that was on the basis of men, and we have found that women sometimes respond differently, so, yeah. Okay, so the big question, what causes autism? As you've probably heard, kind of the prevailing theory not too long ago, and still, there's discussion about this, is vaccines cause it. But the original study they found was flawed. It was a gastroenterologist who tested a group of his children's friends at a birthday party and found some abnormalities physiologically, and it was a small sample. So all the kind of methodology that we want to see in a study was flawed. So they've tested that over and over again with better experimental methods, and they found that does not cause autism. There used to be, I think it was mercury as a preservative in the vaccines quite some time ago, and there was concerns about that, but that's been removed from vaccines since the 90s, I think. So kind of where we're going with things is that ASD occurs, it has something to do with like conception or in utero development or things shortly after birth. That's kind of where the research is going, but there's always exceptions to that. So it's a complex, and there's multiple pathways to autism. So we're looking at genetic factors, we're looking at environmental factors, and we're looking at what's called epigenetics, which is environmental factors that may set off certain genes. So you may be predisposed to something, but something in your environment or something in utero doesn't activate that particular gene. So just because you may have a family member with schizophrenia, that doesn't mean that you're prone to schizophrenia, for example.
To make sure that I fully understand what you're saying, is that we still don't know what causes autism.
We have a lot of correlational things that we've discovered, and correlation is not causation. So, for example, you'll see in the next slide, they're looking at pesticide exposure, and so just because you're exposed to pesticides doesn't mean that you develop autism, but they're seeing a higher incidence of autism in that kind of group. Does that answer?
Yes.
Okay.
Since we're down to the genome with regard to the gene, them being able to get down to the gene level, have they noticed any common pattern for people in these various categories under the autism spectrum with regard to their genes, the genetic makeup?
Yeah, there's been certain genes that have been identified, and I don't know, I can't quote them offhand, but a lot of times kids who are identified, when they're first identified, they might refer them for genetic testing to see if they have those particular genes. But I saw something recently that they're looking at even smaller parts of the DNA and how they process.
So at this time, they don't have anything that says there's a genetic predisposition.
Actually, yeah, I would say they do. Let me flip to the next slide.
I'm sorry.
No, you're fine. So we know that in twins, there's a predisposition. We know that if you have a sibling who has autism, that puts you at greater risk. So we would definitely want to, monitor that child more closely. So in identical twins, 36 to 95% of the time, the other twin will have an autism diagnosis. Now, sometimes the diagnosis can differ. One child could have more severe needs, and one child could be very, very mild. And sometimes they'll think that the other child is fine, but it's not always clear early on for some children because they have good, maybe they're social, they want to join, they have good facial expressions, relatively good eye contact. But then when they get into, when they're 5, when they're 6, or maybe even older, and they're having conversations with people, and you wouldn't expect your 2-year-old or 3-year-old to have fabulous conversation skills, but when you get older, that's a skill that we would want to see. Thank you. Sorry. That's okay. And when social relationships get more nuanced, you might see some more difficulties. How am I on time here? Okay, so we know that in Fragile X, tuberous sclerosis, there's a higher incidence of autism. And as I mentioned, if there's a sibling with autism, that too. Even, a family member, and sometimes what we'll see is what we'll call a phenotypical pattern in the family. So maybe there's an uncle who always had social difficulties and was kind of considered, to have some different kinds of interests, and maybe they're not on the spectrum, but they show some qualities of that. So maybe there's a family phenotype of autism too. Something that's been found, length between pregnancies, and this is also with other developmental disabilities, I believe. So babies that are conceived less than 18 months after the previous birth, or more than 5 years after the previous birth, are more likely to have autism. Parental age, I don't know the exact ages. I think I heard they think it has something to do, maybe more with the father, age 40 plus. Babies that are born too early, too small, or cesarean section. And these are all correlational factors again. It's very, 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 very complex. It's impossible to control for all factors in a study when you're looking at real people. And again, there may be the interaction of different things going on. They found Valproic Acid, thalidomide. Valproic Acid is a seizure medication, more likely to cause autism. Thalidomide is used for different things, and it was more common earlier on, and I think it might be used for cancer sometimes too. Does anybody know? It was a popular drug in the earlier period, 50s, 60s, I think. This you may have seen this in the news, antidepressants, SSRIs during pregnancy. So one study said, yes, that's a risk factor. More recent studies are saying that, well, when we controlled for additional factors, we found that taking SSRIs place you at a greater risk of having a premature birth. So it's the premature birth factor, not the drug that's caused that. Or it's the general state of the health of the mother rather than the medication. So again, it's also very hard to get a sample that is exactly identical. So there may be, some cases that do, some cases that don't. There's always exceptions to the rule. Questions? Did you have a question? No? Okay. Opioid use, this is looking at prescription opioid use, though I suspect that illegal opioid use isn't good either and probably puts you, well, we know it's not good, but puts you at an increased risk of having a child with autism. So shortly before conception even, or during pregnancy. Pesticide exposure, families that live close to agricultural sites that use high doses of chemicals. This came out recently. You may have heard high levels of DDE in the mother's blood, and like 80 to 100% of women show pesticides in their blood, which is kind of scary, right? But but not all of those women have children with autism, obviously. So, but this is DDT, which is not used anymore, but they found that it takes decades for that to break down in the food system, in the food chain. So people are still getting exposed to it, even though it's not actively used in the United States. This is a study done in China. So dioxin is a form of air pollution, comes from like industrial emittance and car emissions. Exposure during certain periods of childhood, they found a higher incidence of kids that went on to develop autism. So the signs begin in early childhood and typically last throughout a person's lifetime, although things can wax and wane depending on what's going on. And as I mentioned, parents often notice that something's not quite right. It may not be, oh, I think my child has autism, but it's something developmental. So the screenings they recommend, it's 9, 18, 24, and 24 to 30-month visits. So here are some red flags by age that might be noticed, that might bring up concern in a doctor's office or have the child present for testing with a psychologist. So facial expressions by 6 months, so those varied facial expressions, back and forth sharing of cooing, smiles by age 9 months, not responding to their name by 12 months, no babbling by 12 months, no pointing, showing, reaching, or waving by 12 months. Gestures, it's also important to look at those a little more closely because sometimes, an individual might point to something, but they never look back to see if the person with them is looking. So it's all about getting your attention. We can use words, we can use facial expressions, we can use gestures to get somebody's attention. So you want to see, they're pointing and they're looking back, and that's called joint referencing. So we want to see that too. So sometimes people will think, oh, they're fine, they do this and that, but again, it's a quality that we're looking for. Even eye contact, maybe where are they looking? Like sometimes people will look, towards your chin or over on this side or that side, and it looks, maybe like they're making correct eye contact or it's too intense. And we don't look 100% of the time. We have subtle changes or it's fleeting. So again, that's a quality issue. No words by 16 months, no pretend play, no 2-word meaningful phrases, these are authentic ones, so we're not just repeating what we heard by 24 months, or any loss of speech, social skills, or babbling at any age. Behaviorally, this is not necessarily by age, but these are things that might be a red flag. So avoiding eye contact, preference for being alone, trouble understanding feelings, continued delayed language skills, repeating words over and over again, being upset by minor changes, those intense interests, flapping hands, those motor movements, unusual reactions to the way things sound, smell, taste, look, or feel, giving unrelated answers to questions, so not really kind of paying attention to the context. And that's not all of them, that's just some of them. So when a child comes to me, this is what an evaluation typically looks like. So I would meet with the parent to review the presenting concerns, the child's background, get more information about their development. We would have the parent, fill out some background history forms, looking at their current presentation and past presentation. Sometimes the interviews will extend to teachers or the client, depending on the age. And we look at symptoms of other mental health conditions. So that's called comorbidity, when two things occur at the same time. And comorbidity is really quite common in autism. And if you want to help the person most effectively, I think it's really important to look at all of that too. And then also to look at things that may overlap. As I was talking about the subtle kids, if we were using the old kind of classification, maybe the kids are more likely to go Asperger's or PDD-NOS. They often get diagnosed with like ADHD, or maybe anxiety when they're younger, or like early elementary school, and then they start to, their clinical picture becomes clearer, or maybe they're just misdiagnosed, and not that they don't have those things too, but it may have more like deeper underpinnings. So I would be looking at their behavior in the sessions, and if needed, like out in the school settings if that's available. We'd be doing some rating scales, autism-specific skills, like the Autism Spectrum Rating Scales, ASRS, to look at comorbid conditions like ADHD, oppositional defiant disorder, anxiety disorders, depression. We would be doing these other types of scales. We'd be looking at how much help they need in their environment, so adaptive behavior. And the gold standard for autism assessments is called the ADOS, the Autism Diagnostic Observation Schedule. So it is a play-based assessment and kind of a conversational assessment. I like to describe it as it creates a microcosm for viewing the individual's skills, strengths, and weaknesses, and their needs as they might, show them in the real-world setting. So depending on the child's age, we would play together, and we would, I would ask them questions or try and start conversations. I would watch them use some gestures and demonstrate tasks. There's different skills by age group and language level. And the youngest children we're looking at, do they respond to their name? Do they make eye contact? Do they use a point? Do they request things? Those sorts of things. Looking at cognitive ability is really important for understanding strengths and weaknesses. Academic achievement sometimes, as time permits and as needed. And it's important to look at other facets of development. Psychologists wouldn't be doing this necessarily, but sometimes children, when they're first diagnosed, will go through interdisciplinary clinics, and they'll have a speech-language therapist and OT/PT evaluating them as well. Although when I am testing really little kids, I will do a developmental test that looks at those areas of functioning to say, do they have a developmental delay in any of these areas. But it's not in depth like a specialist in that area would do. Okay, so it can be difficult because there is no medical test. Although I've heard there has been a blood test. I've seen it advertised. I don't know anything about it though. I hope I'll have a job in 10 years. But you have to reinvent myself, who knows. But to see if a child is at risk. And as I said, you know, unfortunately I don't know a whole lot about this yet. But I hope that, that's exciting. It's exciting technology, and then, you know, more kids will have access to screening and more kids will get the earlier intervention that they need. But I don't see how, you know, even if there is a medical test, how that will give you a depiction of the individual strengths, weaknesses, and needs. So I think that, you know, those kind of traditional assessments we do right now will still be valuable in understanding the child's profile. So we already talked about that some. Here at Ridgeway Academy, we do autism assessments regularly on an outpatient level if somebody is looking for an evaluation or a reevaluation, or for kiddos here that maybe there's concerns that something else is going on, or we need an updated assessment for county board services, or just to see what's going on. We do those. And so the average age last reported, I believe, is around 4. So, you know, it would be advantageous for us to get better and better at detecting. I think that, you know, to go back to your question too, I think it probably starts with the primary care doctors, because when they're really little, they're the ones referring to us. So, yeah, so as they get better at screening and knowing what they're seeing and more proactive, I think in the past a lot of doctors would be like, oh, let's just wait and see, don't be worried about it, and, you know, kids develop at their own time. Now they're being a little more proactive, I think, so they're referring out to get some more information, and those screening measures are hopefully capturing more kids.
Better safe than sorry, because early prevention is the key, right?
Yeah, I mean, you definitely have a lot better, you know, outcomes and growth the earlier the intervention is started. And I tend to be kind of more proactive, and the whole wait and see approach bothers me as a professional and a parent. I would be very upset if somebody said, let's just wait and see. No. So that's kind of, you know, how I approach things. And as I talked about, people with more subtle symptoms may be diagnosed later in life when life is more difficult. You know, even adults are diagnosed sometimes when they move into the workforce. They can't hold down a job. They're fired. They can't just, you know, they know how to do things, but they just can't get their, you know, lives together to do the things that they need to do to be independent. Sometimes they'll present for assessments too, or, you know, they're having failed romantic relationships and things. Comorbidity is common. This one study found that actually this is kind of a grouping of all those past studies, but anxiety disorder is pretty common. Ranges from 17 to 84% of people with ASD also have an anxiety disorder. This particular study found that obsessive compulsive disorder was quite high, and kids with autism do have repetitive behaviors that sometimes it can be hard to distinguish this as just repetitive behavior. In autism, like everything has to go back in a certain way, you know, when they're cleaning up their room or something like that. But if they're very, very distressed when they can't perform these rituals, then that's kind of a key that maybe something else might be going on. Specific phobia, so it can be fear of tornadoes, fear of water, fear of dogs, fear of bugs, those sorts of things. That's quite common in ASD. ADHD is pretty common, and prior to DSM-5, you were not allowed to diagnose ADHD with autism, interestingly, because they felt that ADHD symptoms are just kind of a part of autism. But we would still say, you know, with significant ADHD symptoms, because it's important to kind of flag these things so people know how to help the child best. But now we can actually give a separate diagnosis of ADHD. Oppositional defiant disorder, 7%. Okay, there's currently no cure, but as we were talking about, early intervention is key. So early intervention is at birth to 3, and it can take place whether or not they have that formal diagnosis of autism. Some children just have a developmental delay. ABA, applied behavior analysis, is kind of a gold standard treatment in autism. For little kids that are getting diagnosed, they're saying 25 to 40 hours per week. If they go to an ABA-based school like Bridgeway Academy, then some of that can take the place of that, not just in-home therapies. Speech, OT, PT are common therapies too. This is more about ABA, but since there's another presentation dedicated to that, and I am already pushing time, I'll kind of skip over that, but you can, read through it. There's different forms of ABA, and ABA is not just for autism. ABA is through, the principles of reinforcement that we kind of live out in our daily lives. We get paid to go to our jobs, so on and so forth, kinds of things. But ABA can be effective with other kinds of needs too, like ADHD. Even when I'm working with a child who, has autism, anxiety, I'll, integrate some of those principles too. I think reinforcement systems can help you to develop habits and be more mindful of what you want to build and what you want to change. And the ABA can expand to different areas of functioning. And it can look different from child to child, and it can change from different points in your life. There's a cool video there if you want to check out that link. These are some other noteworthy approaches. I use cognitive behavioral therapy when appropriate with a lot of my kids. So the psychologists here do counseling and testing. And so CBT focuses on the interactions between thoughts, feelings, and behaviors, teaching coping skills. So even when we're doing that, I'm usually integrating some elements of ABA too. So we have a reinforcement system to practice your skills. We have, the skills broken down into a visual schedule or kind of step-by-step format and those sorts of things that help. School services, often kids will have an IEP, they'll qualify for an IEP, maybe under autism, maybe under other health impairment, maybe under speech impairment. But the unfortunate thing is an autism diagnosis does not guarantee an IEP, and I have run into this situation before. And it's always unfortunate when it happens, so the school wants to see that autism is having an adverse educational effect on a child's functioning. So particularly I see the pushback in younger grades for the kids that have well-developed skills for their age, but they're going to struggle in certain aspects that are very, very relevant, and they're maybe not going to show those skills because they, have trouble with the transitions or trouble working with peers and those sorts of things. So sometimes schools will push back, and so the diagnosis does not guarantee an IEP. Or sometimes they'll be put under different categories, or they'll qualify as a preschooler, which is, I think, easier to do. You have these developmental delay categories and stuff, and then you get more specific as you get older. So an IEP for a child with autism might address academics, behavior, self-help skills, social skills, emotion regulation. They may have speech therapy, OT, PT, adapted phys ed. Other services a child with ASD might receive, music therapy, counseling, social skills groups. Oh, that's it. Any questions?